Hi, in this video, we'll be talking about the metabolic response to injury. And we'll be discussing why that is important when it comes to the management of any post surgical or trauma patients. So, what happens is if there is any injury, be it surgical or be it traumatic, to any tissue, there are a set of systemic changes that take place. Now, these systemic changes affect the functioning of vital organs, which is brought about by hormones, cytokines, and neural circuits. Now, these set of systemic changes that take place altogether are called the metabolic response to injury. Now, the management of this metabolic response has an impact on recovery as well as survival, and that is why it is important to understand what it entails. Okay, so we'll start off by understanding what homeostasis is. Now, homeostasis is maintaining a constant internal environment where the cellular processes function optimally. So it is an optimal internal state which allows maximal function of body systems. Whenever there is any sort of injury, it affects this homeostasis, and typically it is divided into a catabolic stage and an anabolic stage. So the initial stage, the initial response of the body is catabolic, which then converts to the anabolic stage. So let's understand the catabolic stage a little better. Following injury, there is a state of hypovolemia, could be shock, reduced basal metabolic rate, reduced cardiac output, hypothermia, and lactic acidosis. Now, the entire aim of this stage is to conserve the circulating volume and the energy stores for future recovery. So it prepares the body following a trauma or an injury for survival or for recovery in the future. This catabolic stage is then followed by a stage of hypermetabolism, where there is muscle breakdown, weight loss, hyperglycemia, which we will see in a little more detail further on. Okay, so every individual responds differently to any sort of injury, which depends on certain factors. For example, the magnitude of the injury is one of the factors which is very important in terms of the response. This is a very important image when it comes to understanding the response, the metabolic response. We see in this. So, in this image, it is evident that in cases of major trauma, there is a higher response and it takes longer time to return to the baseline, whereas in cases of minor trauma the response is not as much as major trauma and it returns back to the baseline pretty quick, which is also the case with nitrogen excretion, which parallels the hypermetabolic state in terms of protein breakdown. This response that we just saw is called the graded response. So one important aspect of the metabolic response to injury is that it is graded. It depends on the magnitude of injury. Now we shall take a look at the mediators of this metabolic response to injury. We need to understand two mediators. One is the tissue damage and inflammation. And secondly, we have the neuroendocrine response to injury. So, starting off with tissue damage and inflammation. Whenever there is any injury to any tissue, for example, this tissue, there is an injury. This leads to the release of damage associated molecular patterns, also known as alarmins. Now, these damage associated molecular patterns are sensed by pattern recognition receptors like toll like receptors, nod like receptors, which are located on cells like neutrophils, macrophages, and your dendritic cells, which are the cells of your innate immune system. So once the neutrophils, the macrophages, or the dendritic cells, the pattern recognition receptor gets activated by these dams, they attract further cells, they activate these innate immune cells, and this activation has two responses. One is the intracellular inflammasome formation. So what do these inflammasomes do? These inflammasomes, they activate caspase, because of which there is release of interleukin 1, interleukin 6, and also if you remember from your pathology chapters, these caspases are also important in cell death, the programmed cell death. So that is a function of these inflammasomes. Secondly, the activation of these cells releases interferons, chemokines, and tumor necrosis factor. This entire process of activation via damage associated molecular patterns that we just saw can also happen in endothelial cells as well as platelets. Now, the consequence of this would be increased vascular permeability and coagulopathy, which would ultimately lead to local ischemia because of changes in the microcirculation. And this ischemia will produce more damage associated molecular patterns. So, what started as a local inflammation process for the tissue repair, when it gets uncontrolled or prolonged, becomes a risk factor for this systemic malfunction, such as your acute kidney injury, acute lung injury, coagulopathy, multi-organ dysfunction syndrome, your organ failures. Okay, and you would say that we can, create, we can develop a therapeutic blockade to these mechanisms. But one thing to note is that the damage associated molecular patterns, they can activate many receptors and different pathways, because of which development of these therapies have not yet been possible. Okay, another thing to note is that this secondary activation of the metabolic response to injury, that is further creation of the damage associated molecular patterns, apart from the injury itself, can occur due to certain other factors. For example, secondary triggers to metabolic response to injury. Other factors would be factors such as sepsis, hypovolemia due to either volume loss or due to hemorrhage, massive transfusion, acidosis, surgery, crush syndrome, and ischemia, reperfusion. So let us revise tissue damage and inflame the tissue damage and inflammation pathway of the metabolic response to injury. Any injury will release damage associated molecular patterns, which can activate the pattern recognition receptors, which are either located on the cells of the innate immune system or on endothelial cells and platelet. It has certain effects in the form of attraction of other innate immune cells, activation of these cells, which leads to release of interferons, chemokines, tumor necrosis factor, and the formation of intracellular inflammasomes, which activate caspase. And caspase can further release interleukin 1, interleukin 6, or lead to cell death. And the activation of endothelial and platelet cells would lead to increased vascular permeability, coagulopathy, which would further lead to local ischemia and further release of damage associated molecular patterns. So it is very important that this entire system of local inflammation is brought in check, so that the aim of this local inflammation, that was tissue repair, is realized. Okay, now we'll move on to the neuroendocrine response to injury. So the nociceptive neurons, they get excited by one, local inflammation, which we just discussed, and by direct injury. So activation occurs by inflammation as well as direct injury. Now, these nociceptive neurons, they ultimately terminate into the hypothalamus. The tract goes via the spinal cord, the thalamus, the hypothalamus. So this ends up in hypothalamus, which releases corticotrophin releasing factor. Now, this acts on pituitary gland and ultimately leads to the release of ACTH. Now, the function of the ACTH is it acts on the adrenal gland and leads to the release of cortisol, ADR, other hormones such as glucagon. These are the counter regulatory hormones. Along with this, there is also increase in the level of growth hormones, whereas hormones which reduce during the acute phase of injury would be insulin, IGF-1, insulin growth factor 1. There is a reduction in the thyroid hormones, particularly T3, and there's a reduction in testosterone. So the rise in these counter regulatory hormones lead to certain metabolic changes like lipolysis, will lead to protein breakdown, will lead to glucose mobilization, and will lead to hepatic acute phase reactants increase. And these interleukins also act on the hypothalamus and cause pyrexia. Let us now understand this hypermetabolism in a little more detail. So, in cases of trauma, the metabolic rate could rise to the levels of 15 to 25% above the normal healthy resting values. And the cause for this is multifold. One, we have seen pyrexia. So this central thermo dysregulation will lead to increased metabolism. The abnormalities from wound circulation, that is your increase in the lactate. Increase in the lactate would require the activation of the Cori cycle. Cori cycle requires ATP and also the increased sympathetic activity. So this leads to hypermetabolism. Okay, so the consequence of this hypermetabolism would be the skeletal muscle wasting, which is seen in prolonged catabolic states. And if the respiratory muscles get involved, that could lead to hypostatic pneumonia. That could lead to increased morbidity and increased mortality. So coming to the alterations in skeletal muscle protein, there is increased breakdown due to the ubiquitin proteasome pathway. And as a result of this, there is increased release of amino acids. And and this cannot be counteracted by hyperalimentation, which is excessive feeding, because that in itself poses a metabolic stress. So the aim of feeding in such patients should be to attenuate this metabolic response rather than replace the energy and protein losses. So treating the hypermetabolism and alterations in this skeletal muscle protein metabolism would be via providing supportive care, ensuring temperature regulation, bed rest, proper ventilation, and treating the septic episodes. Now, coming to the hepatic acute phase reactants, there is a rise in these reactants which act as a double-edged sword, because it provides the proteins which are important for recovery and repair, but these acute phase reactants rise at the expense of lean tissue and energy reserves. And finally, coming on to hyperglycemia that occurs as a result of one, the increase in the glucose mobilization, two, the initial reduction in insulin. Following the initial reduction in insulin, the insulin does start to rise. However, there is a peripheral insulin resistance which is encountered, and it depends upon the degree of this catabolic response and the duration of the catabolic response. So the issue with hyperglycemia is that it leads to the formation of reactive oxygen species, which further aggravates the inflammatory response. So the mainstay of management of insulin resistance is IV insulin infusion, which is used to keep blood glucose levels within a reasonable limit on the basis that this will reduce both the morbidity and the mortality. So, once again, let us take a look at the neuroendocrine response to injury. So, the nociceptive neurons, which get excited by local inflammation and injury, carry this information to the hypothalamus, which releases corticotropin releasing factors, which further leads to the release of ACTH. ACTH acts on the adrenal gland and, along with cortisol, ADR, and glucagon, lead to the release of growth hormone. Subsequently, there's also reduction in insulin growth factor 1, thyroid hormones, and testosterone. The effect of these counter-regulatory hormones would be hypermetabolism. And as we've discussed, the metabolic rate may rise up to 15 to 25%. There is an increase in the hepatic acute phase reactants, and there is hyperglycemia. Due to the effects of the interleukins, the local inflammation, there is also pyrexia, as it leads to central thermodysregulation. So this in all is this entails the mediators of the metabolic response to injury. So since we have got the agonists to this inflammatory response or to this metabolic response, we also need to have certain antagonists so that this process does not go on forever and it is brought in check. We have got two sets of antagonists. One are the local acting and the other are the systemic ones. So the local mediators are known as your specialized pro-resolving mediators. SPMs, specialized pro-resolving mediators, and examples are many. You have resolvins, protectins, etc. So what they do is they clear the apoptotic neutrophils, your microbial particles. They reduce the pro-inflammatory cytokines. They remove cellular debris and they bring about the clearance of apoptotic neutrophils, the ones which are activated by DAMPs and the microbial products. We've also got systemic antagonists. For example, we have interleukin 1 receptor antagonist, and we have tumor necrosis factors soluble receptors. So the aim of this antagonistic system is to bring this inflammatory reaction that is taking place into control. However, sometimes what happens is there is an overactivation of this antagonistic system. Overactivation will lead to immunosuppression and anti-inflammatory response, which will further lead to increased opportunistic infection, and this is known as CARS. What does CARS stand for? CARS stand for compensatory anti-inflammatory response. So over and under of both is detrimental. And one thing to note is that this response that a particular individual has is assumed to be genetic because because different individuals respond to the same kind of trauma differently. Okay, next we'll take a look at the changes in body composition following injury. So here what we need to understand the body composition. It consists of fat and lean body mass. Lean body mass is further divided into proteins, water, and minerals. This will be further divided into skeletal muscle proteins and non-skeletal also or visceral proteins. Water will be your intracellular and extracellular. Okay, so the main labile energy source, okay, the main source which is lost in cases of any starvation body loss, or any trauma would be fat and protein. And in protein, it is particularly the skeletal muscle proteins. But we need to take note that in cases of starvation or loss of weight, the breakdown of protein, which is witnessed or which is noted by the urinary nitrogen excretion, is attenuated by a series of adaptive changes. That means after a particular protein loss, there is a capping, but this does not occur following a major trauma. So what happens is that this patient or the injured continues breaking down this protein, which is witnessed in the form of the urinary nitrogen loss. And once the body protein mass has reached 30 to 40% of the total, the survival is unlikely. Because again, as we had discussed, it leads to hypostatic pneumonia, it leads to increased morbidity and increased mortality. So what happens in these patients who are admitted in the ICU once we start resuscitation? There is an increase in the extracellular fluid in the first 24 hours, but the protein will diminish in the next 10. We might note an increase in the body weight, but this is due to the extracellular fluid and not because of any um, fat or muscle gain. But following approximately 10 days, the body weight will reach negative balance as this expansion of this extracellular space resolves. And it is now that we need to bring this protein breakdown under control, which can be achieved by blocking this neuroendocrine stress response. Now, how that is achieved in modern surgeries is by analgesia or other related techniques, providing early enteral feed. And this forms the basis of ERAS, which is your enhanced recovery after surgery, which will be dealt with in the next video. So let me just show an image of this of the changes in the body weight that occur in serious sepsis, okay, after uncomplicated surgery and in total starvation. So here in sepsis, we see that there is an initial rise, and we discussed that this initial rise is due to the expansion of the extracellular fluid volume, and then it reaches negative balance because this extracellular fluid expansion resolves and there is a breakdown of protein. However, in uncomplicated major surgery, since the patient does lose protein because of the metabolic stress, there is a decrease in the weight there is a decrease in the weight that occurs, and following starvation also there is a decrease in the weight. And we've already discussed that this occurs because of the protein and fat breakdown, which are the labile energy reserves. So taking care of this catabolic response to injury becomes very important when it comes to optimal outcome of a particular intervention or to reduce morbidity and mortality following trauma. And we have seen multiple ways to achieve this. For example, in cases of elective surgery, to ensure adequate pain relief, to avoid hypothermia, to avoid preoperative starvation, limit the intraoperative fluid administration, and to ensure early oral feeds. And in other cases, such as sepsis, to identify the source, to resolve the sepsis, to ensure adequate ventilation, paralysis, bed rest, temperature regulation, and to ensure normoglycemia. So that is all for this chapter, but we will be covering enhanced recovery after surgery in the next video. The entire idea of ERAS is based on the metabolic response to injury. Thank you so much for watching this video. If you did find the concept a little easier, do hit the like button. Please subscribe and share this video as much as possible. Thank you.